So
Welcome, everybody. Thank you for joining us for this incredible discussion. Today's discussion centers on the reality that many people in healthcare leadership still underestimate. And that's when sterile processing breaks down, it rarely fails loudly at first. It kind of a series of small events where the people who are responsible don't have the authority to fix it. And to discuss this topic, we couldn't have a better expert than my friend, Shawn Flynn. Shawn Flynn is the business unit director for sterile processing at Skytron. Shawn Flynn is an inventor. He invented a great thing. Shawn Flynn is also pretty much responsible for the only state south of the Mason Dixon line that has a certification requirement, and that's Tennessee. And Shawn Flynn was in the Army because he couldn't join the Navy. Joking, joking. But we go back a long way. I'm excited to hear his thoughts. He is a subject matter expert, no doubt. And with that, Shawn, welcome to our workshop and tell us what we need to know about the breakdowns that can happen in sterile processing.
well, thank you, Jameed, and I'll have to get you back on the whole Army and Navy thing, but and I actually believe we won this year in the Army Navy game. But anyway, um, so yeah, Jameed, me and Jameed go way back, and in sterile processing, and I've amassed in the last 30 plus years in my career in this space a tremendous amount of friends and people that I've networked with, and Jameed is definitely one of them. Um, this particular topic, kind of hits home, more specific to me. As for those who don't know, I was an expert witness on a trial that took place. Uh, Basically, in a nutshell, what happened was the surgeon decided to IUSS some implants on a particular case. Um, so let me just start by saying or giving you a scenario. So surgical case is ready and underway, right? A patient is anesthetized. The incision has been made. And so when I'm running through this, picture it in your head. If you're in surgery, if you've never been in surgery, just picture what I'm saying, or try as best as you can. So, and then someone in the room realizes something critical is missing. Maybe it's an implant, maybe it's a screw set, maybe it's an instrument tray that never made it through sterile processing. Now, suddenly, the entire room feels a tremendous amount of pressure. So the surgeon is waiting, the team is waiting, the clock is running. Now, all this is transpiring in surgery in real time. And someone says, can we IUSS it? Right? And at that moment, there's a decision that has to be made. In most cases, sterile processing isn't in the room when this is being decided upon. And that gets me to what we're going to talk about today, which is this is a real case, a real person, a major league soccer player, athlete, where a decision was made under pressure that ultimately resulted in his initial surgery and 14 surgeries thereafter to mitigate a surgical site infection as it relates to IUSS screws and plates. And as a result, the jury trial took place with a almost unanimous verdict of negligence to the surgeon to a tune of $20.6 million. And for me, it hit home because this is a real case. I've seen it so many different times play out this way in surgery and in sterile processing. And unfortunately for me, having been both in the OR and in sterile processing, those are two extremely different dynamics. And fortunately, we're going to be having a panel discussion, opening keynote discussion at this year's HSPA, with a reception afterwards where Jake Gleason, the actual patient, will be on the panel as well as available at the closing reception or following the keynote, and to answer any questions and to basically advocate for those individuals who work in sterile processing on a day-to-day basis to be empowered to do the right thing. Now, having said that, let me walk through this particular case, right? So it's a normal case. Jake comes in about 1:45 p.m. in the afternoon. It's the last case. I believe it was the fourth case in that particular OR. And he comes in, has his pre-op, um, goes into the room. And at this point, I believe nothing was actually set up in inventory, right? So for those who scrubbed in on cases before, you know that what you optimally want to do is set up before the patient comes in and assess your inventory. Well, this wasn't done. So for me, this was the first obstacle, first hurdle, a mistake that happened on this particular case. So Jake gets put under anesthesia. Um, they sangulate the leg. I believe the left leg is what they started with, and proceed to start with the case about 3:36 p.m. Um, so again, pressure in the room. You know, case is going pretty smoothly, but there's still pressure in the operating room. And roughly about, I would say, 45 minutes later, they discover that this particular plate and screws are missing. So they're doing bilateral, left and right plates to support shin splints for his particular injury. And at that point, the decision was made by the surgeon to borrow a implant set that had the corresponding plate and screws in it from another hospital. This hospital was not affiliated with this ambulatory surgery center. It was a neighboring hospital. And as you know, there's no guarantee of how that implant set was reprocessed, nor where it was reprocessed and how it was reprocessed. When I audit hospitals, I would go out, and some of them, particularly ambulatory surgery centers, wouldn't have a ultrasonic washer in their department, but yet they do a lot of orthopedic and spine cases. And in some cases, I've even been there where they didn't even have reamer brushes. But that's, I won't get into all that. But so I say all that to say there's no guarantee of how this set was processed. So they basically make the decision. The surgeon says, go borrow this particular set. Again, Jake's on the table. It takes about 30 minutes to go get this particular set and bring it back. And for those of you who are in sterile processing, you also then know what the pressure is to get this set reprocessed and ready for that particular case because the patient is on the table. And from an authority standpoint, particularly in the ambulatory surgery center, you have a surgeon telling the team what to do versus everyone adhering to policies and procedures. And so roughly about 4:44 p.m., that IUSS cycle begins. And remember, I said the set came around 4:30. So you've got basically from 4:30 to 4:44 that instrument set to be cleaned and properly decontaminated. Now, I've been in sterile processing a long time. I've been in the OR a long time. I have never seen anybody take a screw caddy out, take the individual screws out, and clean those individually once they receive them. And so if you look at the IFU of this particular case and decontaminated according to what the IFU says, there's no way that they could have cleaned this and decontaminated this according to the IFU in the time frame that they did between the time they received it from the time that they put it in the sterilizer. So you have that issue, right? An abbreviated cleaning process leading up to sterilization. Okay, so IUSS begins at 4:44. The case then, continues. They're prepping Jake for the right side. Now, in the OR, what's happening is there's pressure mounting and building up because that surgical team is now wanting that set so they can continue on with the case and get Jake off anesthesia. Okay, conclude the case. So you have that aspect of it. At 4:45, the surgeon signs the early release form because at this particular point, the biologics aren't passed to let the team know that everything met its parameters and that the biologic basically had passed and they have verification that it passed. So he signs the early release form, and then shortly thereafter, I believe at 5:01, the door opens for the sterilizer to be put into the room. Okay. Now, I'll transition to the next slide because this gets important when you're talking about transitioning an IUSS set into the operating room. So it comes in and it's very hot. Okay. And when it's very hot, they have to cool it down. So they'll transfer the sterile items onto the sterile back table. They cool it off with sterile water. Well, if there's any air contaminants, that contaminants in the air could wick onto the actual implant. So now I've introduced two factors that increase the risk of that surgical case or Jake having an infection. And again, this was not an emergency case. So let me preface by saying this was a routine scheduled case, not an emergency. And if I was having surgery or a family member was having surgery, I do not want them increasing the risk level of a particular procedure when surgery is already risky, right? So there's two factors where are right off the bat that they've increased the risk of this particular case. And this is one of them. And if they can play the video again, what you'll see is as they're rinsing off the particular implant, over time from the transfer of the back table to the surgical site, again, any contaminants in the air, it's going to wick onto that implant and screw. Secondarily to that, you have the abbreviated cleaning process. And we all know if you don't clean it properly leading up to the sterilization cycle, you can't sterilize organic matter. And so you have those factors at hand. 2 or 3, there was no ultrasonic cleaning in this particular facility. So any debris that might have been on there from a previous case or previous process would probably still be on there. Okay. Now let's look at what the standards say, right? So in this particular case, I actually looked at all the standards and did a crosswalk of AMI, CDC, FDA, APIC, OSHA, ARN, CMS. And if you look all the way to the right-hand column and go straight down, you'll see none of them actually recommend sterilizing implants under IUSS. All right. So again, their own policies and procedures said we don't IUSS implants. The manufacturer's IFU said we don't recommend IUSS on implants. And the governing bodies or the standards organizations equally said unanimously, we don't IUSS implants. But in this particular case, the surgeon argued on the trial or at the trial that he was the standard of care. And I don't have the direct quote with me, but there was a point in the trial where he was asked about, well, what's the reason for the policies in the IFUs and the standards that govern reprocessing of surgical instruments and implants? He said, well, and I'm paraphrasing, those policies and standards and instructions are for the staff and not for me. Okay. Now, I don't know about you, but if I was ever on the table or a family member was on the table having a particular surgery, I would want the entire perioperative team adhering to all of the governing bodies, the instructions for use, as well as their internal policies when conducting surgery on me, family member or friend. Um, and that didn't happen in this case. And so um, the wonderful thing about a trial is that these things come out. And when I was sitting on the stand, um, giving testimony, uh, the one thing that the defense tried to discredit was that I didn't have a PhD in sterile processing. I was not a trained expert witness who had done this before, and that again, I wasn't credentialed enough. He did thank me for my military service, but then try to discredit me thereafter. But what the jury found or knew was, and I said this during the trial, I said there's a difference between the real world and an academic study, or academic studies for that matter. And the expert witness that they brought in defense was somebody who's well respected in the space, um, but basically spoke half truths, meaning just strictly spoke about the sterilization process and how that sterilization process, which passed its parameters, rendered the device sterile. He didn't talk about the abbreviated cleaning process prior to, and he didn't talk about the potential wicking thereafter from IUSSing an implant. And so, very discrediting. But I said to the jury, there's a difference between the real world and the academic world. The real world, where I'm trained from, takes into account the logistics and supply chain of how loaners are transported from one facility to the next. And if you know anything about that, what you'll know is that there's no guarantee that those items are ever cleaned properly in the first place. There's no guarantee that that facility that you borrowed them from had the equipment necessary to clean them according to the IFU. And so, there was other witnesses as well who were expert matter surgeons who said on the stand, and I know this from auditing hospitals, but said this on the stand that this is a frequent practice in many of the surgery centers that they perform surgery on, right? Um, and I can concur that, and validate that because I've seen it. Having said that, is that right? No. It's a manifestation of the imbalance of surgical demand and not having the right infrastructure and staffing and equipment in sterile processing. Um, these are all workarounds. There shouldn't be a situation other than an emergency where you do IUSS, but yet it still exists. And I'll end it with this. Um, Jake had 14 surgeries after this that basically ended his career. It was a combination of debridements, washing. One of his, I believe, the left leg was rotted. Had that removed, had the plates and screws removed, and at the end of the day, his infection was deeply seated in one of the screw holes. And again, a career-ending surgery, all because there were shortcuts taken. And for me, again, it hit home that we have a responsibility in sterile processing as professionals to do the right thing. And in this particular case, the surgery or the technicians weren't empowered to speak up and do the right thing. In this particular case, the nursing staff in the OR didn't speak up and do the right thing. And so my message at HSPA as well as at ARN will be, particularly with ARN, is nursing needs, perioperative services and nursing need to support sterile processing and lift them up. And when they get in situations like this, they need to defend sterile processing. Because in this particular case, the technician had to come in and get on the stand and talk about what her process was. What did she actually do? Now, mind you, this was 4 years later, so a lot of this stuff was not in her memory, because it was so long from that particular case. But she had to get on a stand. She had to defend what she did, and I felt bad because as a surgical tech, she was told to do that, and she wasn't put in a position to where she was empowered to do the right thing. And so, for ARN, I want the message to be empower your sterile processing technicians, build them up when they're competing for capital, and you know OR is wanting a new service line extension. They're wanting to get into robotics. Make sure your sterile processing department has adequate staffing, has adequate equipment, and can actually support the OR in those endeavors, because they go hand in hand. Um, if you're out of balance with anything in sterile processing, I don't care what you do in the OR. If you're trying to push either revenue or patient throughput or combination of the both, um, you're not going to be able to do it effectively if you don't support sterile processing. So that's my message to ARN. And I think Jake will do a great job in talking about the patient side of that. For HSPA, I want people to leave impacted knowing that there are actual patients out here who actually, uh, although they may not see them on a regular basis, that are impacted by the work that they do. And so Jake will be there, the lead attorney will be there, and a good friend of mine, Peter Nichols, which some of you may know, will be there as well. He was a subject matter expert on the case as well. And so we'll conduct a panel interview. Um, this was an opening, teaser to, let you know, but this year will be the opening keynote for HSPA. And I think it's probably be one of the most impactful opening keynotes because it gets right down to the core of what HSPA is about and actually what the core of the job and the responsibility is. So if nobody's ever told you the importance of what you do, you'll actually, hopefully you'll leave that opening keynote with the understanding that your job is just as important as anybody else's job in perioperative services. And without you, they can't do what they do. And I know you hear that all the time, but this is actually a real-time example of the importance of what you do. And I can't specify this enough. Anything and everything that you do in sterile processing has a legal implication for it. I didn't get too detailed into it, but uh, every piece of paperwork that was filled out was a part of an exhibit on this particular case. And when I say I had to go through ad nauseum every record, I had to go through every record and request every record that could possibly be done or written in this particular case. Um, and it kind of shows in the results in this particular case. Um, and if you could put a picture up of the jury um, at the conclusion of, let me see, um, the case, um, we'll actually have the jury um, provide testimony or provide their verdict. And it's quite impactful because there's two questions in this jury verdict. One of them is negligence. Did the doctor or was the doctor negligent in performing IUSS that led to a surgical site infection for Jake Gleason? That verdict was unanimous. So 12 jurors saw the fact that this surgeon inappropriately IUSS these implants and screws. The second question was the surgeon equally negligent for failing to disclose IUSS to the patient? Because it will come out in the keynote that he was never told that they IUSS the implants. So now imagine within 30 days, you develop a surgical site infection and you have no clue of how that infection came about. And then by happenstance, you're indirectly told, oh, by the way, short cycled or IUS, that's the implants during your case. So logically, what do? I don't know what that is, but I'm going to look and see what that is. So he researched what it was and he goes, oh, wait a minute. So you mean to tell me you borrowed some implants, you put it in a short cycle, and lo and behold, the implant that you borrowed is where my infection originated. Okay. Okay. So again, jury unanimous in that verdict as well. And the bulk of his award of his $20.6 million was for damages. So again, the jury was sending a message that this shouldn't be tolerated. And, you know, I was privileged to be on the case. And, Jake says it better than I can. He would trade it all in to be able to play professional soccer again. He started playing when he was a kid, fell in love with the game, and was able to reach that professional level. And for any of you who ever played sports or done something on a professional level, that's your passion. And it was taken away from him. And so we'll get to see his story in real time. And I somewhat still get emotional about it because it affected his family, himself, and he still walks with pain to this day. So again, I wanted to be very impactful for the sterile processing community. I want them to see the value and the worth in what they do. I'm always advocating for sterile processing and the people that make up this community. And my gift of giving back is to present this panel opening keynote discussion about a real world example that this community can play a role in impacting and making sure that this doesn't happen again. And so with that, I will open up to any questions that may be in the background. Because I don't think at this point I know how many people are on, but
Shawn, I really appreciate you coming to share. I can't wait to see the whole rest of the story at both AORN and HSPA. I'm sure it'll be a slightly different slant at both.
yep.
Thank you for sharing. I think if we're honest, especially you and I, having worked in the OR side, this happens way more than we would like to talk about, right? Shawn had such a great impact. Telling us a little bit about Jake, who had the most damaging result. But what about those people who are like they're supposed to go back to work in 4 weeks, but they can't go back till 8 weeks? What about those people who can't ever get back? So I think really when you start thinking about surgical conscience and what our responsibility is on both the OR side and the SPD side, is really an opportunity to kind of sit back. Even if you're unable to come to HSP and AORN, which I highly recommend to see this whole story, especially with the actual patient and with Dr. Nichols and the lead attorney. And what it made me think of, because I'm getting some questions on text because people don't want to do this correctly, but that's okay. That's okay. You can text me the questions I'll ask. You're shy to comment on the LinkedIn. You don't want people to see what your comments are, so I'll blind them. But somebody was asking about the whole idea, when the sterile processing tech had to testify at a trial in which they were following orders. How do you compare and contrast that the responsibility without the authority that we often have? How do we fix that, Shawn?
Wow. A good friend of mine, which I think a lot of is Sharon Green-Golden. So I can't take claim to this. But multiple individuals have to be responsible in signing for that implant to be IUSS if that's the case. So that goes to the surgeon, the nursing staff, sterile processing, and to include the senior executive staff. Somebody on the executive team who's over perioperative services needs to okay that. And I guarantee you, when you put all four of those entities and those titles on that piece of paper, nobody's going to want to sign it. And so
Yeah,
that forces everybody to say, okay, what is the alternatives? Because I don't want to be the one who incurs legal liability and or increase risk to the organization that I work for, nor increase risk to this patient. So
thank you for that answer. It does feel like one of those self-created emergencies, right? The surgeon kind of showed us at trial that he did not feel like it was a collaborative decision to get the tray from the other thing. And then even when we have our emergency release things, a lot of times the emergency we're talking about is the emergency of flashing the implant. And it's, for me, that's a mismatch that we have a emergency release for a scheduled case.
yep.
So really, really, really good stuff. We talk about. I'm seeing comments about how powerful your story was, and the kind of patient advocacy angle. Um, is what are some technology things? Thank you. Shout out Randallin. What are some technology things that we can use from the start of scheduling all the way through the process to hopefully put some guardrails and prevent these unnecessary emergencies from happening?
Yeah, no, this was a total breakdown, and I'm glad you mentioned scheduling. So in this particular case, the case was scheduled, weeks before, and so I believe that Friday before that Monday's case, um, that inventory should have took place. Somebody should have opened that set and said, "Okay, do we have everything in inventory?" Not just because it was a high profile surgery on a high profile patient. They should do that on every case, right? Particularly when implants are involved. And I see it too often when inventory is misaligned with surgery schedule. Um, we're pushing a lot of, surgeries through perioperative, but they don't correlate with the amount of inventory that you have on hand. It gets into an economic issue. Okay, I get it. But if you're trying to do that many cases to push patient throughput and revenue, then that needs to correlate with the amount of inventory that you have. So first and foremost, that set should have been inventoried a couple days beforehand. Um, and when that schedule was booked, when that case was booked, then somebody in sterile processing and materials management, if there was a deficit found in that particular set, should have ordered that implant, right, and those screws, and made sure that they were on hand. Technology-wise, unfortunately, we're still doing a lot of stuff by hand. There are EMRs that actually, can reconcile that, but the data has to be good, right? The data has to match in the EMR as well as the preference card, and then it has to crosswalk all the way to sterile processing to get the information to sterile processing so they know, okay, I have this case scheduled. I need these particular implants. And a lot of times it's in the fine print in the notes section, right, on the surgery schedule that isn't in the actual preference card. So I've seen it where it breaks down at that point because somebody in sterile processing didn't actually look at the notes section, right, when they picked the case. Um, Thereafter, I think there should be, we should get back to the place of setting up a case before the patient comes in the room, right? When I scrubbed in on cases years ago in the military, we had to be there at least 30 minutes before the patient came in the room and have everything set up. Today, I see people coming in 5 minutes before the case and trying to set up for a procedure that has multiple sets. If it's an orthopedic and spine case, you're talking about maybe 10 to 15 sets in that case that you have to set up. And there's no way you're going to inventory everything in 5 minutes to understand if you have everything. So now what happens is you got a surgical tech in the OR who then now in the 24th hour is calling sterile processing and say, I'm missing this particular set or this instrument. And that puts pressure on sterile processing when in fact, if you were 30 minutes before that patient came in the room, and understood. Now we have time to reconcile that, get you another set, right? Get you that instrument that's sterile into your room that's peel packed. That doesn't happen all the time. And in a surgery center, it really doesn't happen because they don't have enough inventory and they don't have enough staff, right? And in many cases, the same technician who is in the OR scrubbing on the case also has a dual responsibility in sterile processing. So, and then your materials management person is ordering for the OR and sterile processing. So it's, so we got a long way to go to answer your question from a technology standpoint. I think there's a lot of advances in computer vision and AI, but again, the data has to be right. If you can put bad data in the AI system, and you're still going to have some of the same issues. So hopefully that answers your question.
That did. And when you talk about ASCs, and this is just informational for people out there, this was a big surgery, regardless of what went wrong. And so, and that doesn't mean ASCs can't do big surgeries. We work with ASCs all the time. Our reputation is big with ASCs, but really the advocacy part is, just because you're an ASC doesn't mean you don't need an instrument management system, right? And so when you're making some of your choices along the way, when you're partnering with some of the things for your purchases, that has got to be a key part of it. The other thing about ASCs that many people who've had the privilege of working in large hospitals don't realize is the infection prevention professional at ASC is usually somebody who's the IP for the whole thing. So it may be a PACU nurse. So, I didn't hear you talk about the infection preventionist testifying. Did they have a surgical services or a perioperative expert IP in that location?
They did. And in the trial, it boils down to each party, on the prosecution side as well as the defense, are going to submit their own experts. And in that, their experts say, well, it couldn't possibly have happened via the implanted IUSS implant, right? On the defense or on the prosecution side, our argument was, well, of course it did. So, it's really, at the end of the day, when it gets to trial, it's about how well you played your case and what the jury thought about that. For me, having worked in the space, is crystal clear. For the experts who, they brought on, it was crystal clear for them that it couldn't have come from the implant because it went through the sterilizer. I got into a pretty large discussion about biofilm, right? None of the experts on their side actually talked about biofilm and how that can promulgate on an implant set, and the corresponding studies that are out there that shows that, right? And I think even since the trial has happened, there's been a couple of studies that show increased risk of surgical site infection to a tune of, I think, 17%. When IUSS was done on implants. So the evidence is out there.
That's a big number. That is a big number, right?
Yeah,
because risk. That's a good point.
Yeah.
One thing you brought up that I had never thought about, and I'm going to be careful because I don't want to mention any particular product names, is I had never thought about the ability for moisture to allow environmental contamination or facilitate it because it's there. So one of the questions that we had from our attendees was the IUSS using one of those systems that allow you to not have dry times? And if it was or wasn't, do you think that the risk that was identified there with the moisture on the implants applies there?
So regardless of the container system that was used, you still have a hot implant and hot screws coming out of the sterilizer. So you still have to cool it down, right? So I have to pour water, sterile water on the back table. That in itself is a
Right.
opportunity, right, for contaminated air to wick onto the implant. Now, I'm glad you raised this point or raised this question because in the trial, I counted 4 trays that could have possibly been used to include an open basket based on the depositions and the testimony that I reviewed, meaning nobody knew what they used. Because I heard 4 different examples of what they could have used. And so for me, that just raised doubt that here you go, you have 4 examples of what people said they used. And then when I looked at their IUSS log, I think according to testimony, they said they didn't do it as often, right? But the IUSS log showed that they on a daily basis IUSS various instruments and in some cases implants throughout the year. So to me, I'm looking at the volume of IUSS based on the record and the log, and I'm looking at the variance in the 4 examples that they gave that they said they used, and then the trade that they actually submitted in trial, which was at that particular time was not even on the market. The company took the tray off the market because of moisture related issues.
Oh,
So,
wow.
so what you have in the trial is it raises doubt on you don't even know what tray you used.
Mm.
And the very tray that you brought into trial wasn't even on the market because the company pulled that tray from the market by the date that you did this procedure. So even if you did use the tray, it wasn't even a tray that the company sold, right?
Wow. Wow.
So, you know, and there was other evidence to include the tray that they submitted in the evidence at the trial. I know based on the volume of IUSS per their log, that this tray or these trays that would be used for IUSS would have had a number of marks on these trays to include marks on the inner seal, the anodized aluminum, the lid itself, which was a plastic lid. And this tray was pristine to me. And so in trial, I vividly remember this question. Our prosecuting attorney asked the question, is this the actual tray that was used on this particular case? And the technician said yes. And I'm looking at the tray. This is a brand new tray, Jimmy.
Mhm.
So I can only infer that this tray was bought after that. And this was a tray that was, being presented as if they were using it. Uh,
Right.
I'll take it to another level. The label that was on the outside was it was labeled IUSS, but done with a label maker with melt under steam sterilization.
Ah,
So it couldn't have been used on this particular case.
couldn't have been late. Yeah,
No.
that's a good point. So my final question is, so we're all going to HSPA, right? Right, gang? Everybody, we're all going to HSPA. We're gonna watch Shawn present. We're gonna get this whole story. Tell me a little bit about this reception afterwards. I didn't get a personal invite from you or Tina. I don't know if I'm on the outs. Tell me about this reception afterwards.
So the opening keynote is one thing. It's going to be, probably emotional because you're going to have Jake there tell his story and then conclude with a closing appeal to all the members within HS. But we felt that it needed to be extended afterwards in a more, probably intimate setting where people can actually meet Jake, ask questions to Jake. He can converse with HSPA members. And so what we did was we actually, in partnership with HSPA, we actually sponsored a reception afterwards. And that reception afterwards is going to take place in the ballroom, same places where the keynote is taking place. And really, so people can have an opportunity to actually meet Jake and talk to him and have him tell his story and them tell their story, on how they, either appreciate what his story has done, some of their, wins, some of their losses, some of their frustrations about, kind of where they're at and how they're not supported or they are supported. Because for Jake, he wants he doesn't want this to happen to anybody else. And so to be in the room with him and to be able to have a conversation with him, we felt it was very important for everybody to engage with him. So that's the keynote reception afterwards. And if anybody wants to talk to the rest of the panel, we'll be there as well.
Thank you very much, Shawn. We appreciate.
Oh, and I can't forget to say this to me. So Miss Sharon Golden is going to be our moderator, and if
Awesome.
you guys anything about Sharon, she's gonna bring it. So.
Well, thank you for joining us. Thank you for all the attendees. I look forward to more partnerships like this between ASSI and Skytron. And I look forward to seeing all the attendees at HSPA.
Perfect. Thank you, everyone.